computer. There we go. Okay, so volume cycled ventilators are, did it click on? It didn't give me a little sign that says it clicked on. Yeah, it's on. Are the type of ventilators that are used on most commonly in the hospital setting for adults. Now, they put these in modes. Now, modes is telling the ventilator how to work. So, there are 3 kinds of modes, and you don't have to go through all 3 modes. You could be on all 3. They could say, well, I'll put them on a control, and then I'll put them on a sys control, and then I'll put them on an IMV control or an SIMV. Or you could just be on SIMV, or you could just be on control. So I don't want you to think that you have to go through all 3 of these modes. You do not. I'm going to go through all 3 so that you can understand how they are, but I don't want you to think you have to be on all 3. You could be on one, you could move to others, but you don't have to. Now, when we're talking about modes, this is probably one of the most confusing things for students to understand about ventilators. It involves 3 things. It involves rate, how many breaths per minute you're going to dial in for the machine to deliver. Breaths per minute, rate. It involves the FiO2. The FiO2 is the percent of inspired oxygen, the amount of oxygen you're going to give the patient. For example, in this room, the FiO2 that I breathe in this room is 21%. The FiO2 in your room is 21%. Room air is 21%. FiO2 is the percent of oxygen that the patient is going to be given. Right? And the tidal volume, the volume. It is usually computed as 10 to 15 milliliters per kilogram of body weight. So that's how they kind of come up with how much tidal volume. Now you can have the actual tidal volume by having pulmonary function study tests, and they do the residual volumes and your tidal volumes and all that. But when these patients come in and they're not breathing, they will say, well, let's send them for pulmonary function studies. Well, no, they'll be dead by the time they get back from pulmonary function studies. So they simply say, okay, how much does this person weigh? Or what do we think they weigh? Or if you're in today's society, how much do the beds say they weigh? And then we can sit there and say, okay, 10 to 15 mLs per kilogram, we should give them this type of tidal volume. So those are the 3 things. There's other things we can dial in, but those are the 3 things that the mode involves.
Hey, Miss Janie.
Yes.
Sorry, this is Caitlin. I think there's Daniel Freeman is waiting to get back in.
I'll change. I know I hit the slide by accident. I will go back. Just a minute. I hit the wrong one. Oh, there's a bunch of people trying to get in. I'm glad you told me because I was down at the bottom.
Sorry to interrupt you.
Well, I'm glad you told me because I forget that she reset that we have to go because, well, it wasn't just Bridget. It was Moodle, not Moodle, Zoom. Okay, I think everybody's been sit back in. So let me go back to, modes. There they are. Okay, so the 3 things are tidal volume, FiO2s, and breaths per minute. Those are the 3 things you dial in. Other things can be dialed in, but they don't have anything to do with modes. All right, so the control mode. The control mode is for people that have no respiratory drive. They will deliver these, and that is all they're going to deliver as a whole, okay? Everything, all the work of breathing is done by the ventilator. So this would be somebody, for example, that is on a paralytic. They have no respiratory drive. This would be somebody with a high C-spine that have no respiratory drive, okay? So this is the ventilator. So for simplicity's sake, I'm going to say we're going to set our rate at 16 breaths per minute. We're going to set our tidal volume at 600 mLs. And we're going to set our FiO2 at 60% of oxygen, just for simplicity's sake, okay? So in the control mode, the patient is going to get 16 breaths per, mine went a little wild up. When I clapped my hands, something came up. I was like, whoa, wow. 16 breaths per minute. with a volume of 600 mLs and an FiO2 of 60. And they're going to get that every single breath, no matter what. The machine will control that. Now, please understand there's other things that are built in there, but as a whole, that's what a control mode means. This is for somebody that has no respiratory drive. That's what they get. There is no more, there is no less. Okay? That's what a control mode is. I will tell you there are some other things in there, but as a whole, that's what happens. They do dial in a few other little things, but as a whole, that's what happens. Okay? Assist control. The control part is there. They will get 16 breaths at 600 mLs at 60% FiO2. That they are going to get that control. All right. However, if the patient has some respiratory drive and decides to breathe on their own more than 16 breaths that the machine is going to give them, when the machine perceives or detects that they took a breath on their own, they will assist that breath and make its tidal volume also 600 mLs. So if he pulls enough negative pressure, they will assist the patient's own breath with the same tidal volume. So the preset volume up to the next stop. So the preset volume will be administered. They will assist any negative pressure breath that the patient initiates, but they will still get the controlled breaths.
Janie, is that the same thing as pressure control? Like
it is not. It is not.
Not okay.
It is not. I'm not going to tell you what that is right now. I'll tell you after we're done with this, okay? I don't want to confuse anybody. Okay. Now, IMV, or intermittent mandatory ventilation, and I will tell you over at CMC, they call it SIMV, which stands for synchronized intermittent mandatory ventilation, SIMV. In this case, they will get the control part. They will get the 16 breaths. They will get the 600 mLs. They will get the FiO2 of 60%. But when the patient initiates negative pressure of a breath, their breath is not assisted. So if they only pull 300 mLs over the 16, they pull more breaths than 16, but they only pull a 300 ml breath, that breath will remain a 300 ml breath. So when it's an assist, it assists the breath to be the same as all the other ones. On the IMV, it does not assist their breath. All they get is the oxygen that's flowing through the machine, the 60%.
Janie, I have a question.
Sure.
So in the assist control, if they do breathe greater than that 16, does it technically knock out that control, or are they still getting that same control?
They still get the same control.
Extra.
They still get the same control. They're going to get those 16 breaths no matter what.
Okay, thank you.
And it's really up to the human that's following this patient to say, you know what? They got 16, but they're actually breathing 24. Do they really need that 16? So maybe they're on the wrong mode. I mean, that would be for us and the smart people of it to say that we're not doing it right. I mean, just to let you and answer your question. We wouldn't let that go on for a really long time. You see what I'm saying?
Yeah.
So, but what we're trying to do is we're trying to get their body to say, oh, let's pull some more. These are good breaths. And so the IMV are for people who are starting to pull more negative pressures. They're starting to take over their respirations. And typically we will start, as they start taking good respirations, we'll start turning down their breaths per minute. But we're going to make sure that they're getting some good breaths in there. So those are the modes. Now, I got to go past the ventilator criteria. Now you have some other things that are dialed in there. And one of this is positive end expiratory pressure. And this is called PEEP, positive end expiratory pressure. Okay. Now, normally you and I, we inhale, our alveoli pop open and gas exchange takes place. Then when we exhale, our alveoli come back down and gas exchange does not take place. So we kind of got to thinking, well, what about if we could maybe not blow them up like a balloon, but you know when you blow up a balloon and it's flat, and then right before it expands, it sort of stands up, and then you give it another push, and then it blows. What if instead of it just being flat, what if we just blew it up, those alveoli, to where they just stood up, but didn't expand, but just stood up? And we made the alveoli round instead of flat. Maybe gas exchange could take place while they were standing up. So that's exactly what happens. On expiration, positive end expiratory pressure. Instead of no pressure being in there on expiration, which is what happens to you and I, at the end of expiration, instead of letting all the air come out, just a little bit of positive pressure stays there. And instead of the alveoli going like this, the alveoli go like this. Not like this when you take a breath, but they go like this, keeping the alveoli round so that gas exchange can take place also on expiration. So I have good, great gas exchange on inspiration, and also some gas exchange on expiration. So who needs this? People that are hypoxic need this, that need more gas exchange. And here's just some examples at the bottom of this slide for you. So we might use some PEEP for people who are hypoxic. Now, someone asked, is this what we call pressure support? Not really. Pressure support on a ventilator, and that's where you use pressure supports on a ventilator, okay, is like CPAP for people that are not on a ventilator. That's keeping the airways open, but they're breathing on their own. So a patient that's on a vent, but they're doing well breathing, but we're not really quite ready to extubate them yet because we don't believe in them quite yet, but their gases are good, their pulse ox is good, they're breathing a good number per minute, they're pulling good negative pressures, and we think we're going to get ready to extubate them probably really soon, maybe tonight or tomorrow. Let's go on and let them keep the ET tube in. Let's let them do all their breathing on their own. But you know what? Let's give them just a little bit of just pressure so that they don't have to work quite as hard. It's almost like giving them a little bit of oil for a squeaky door, or a little bit of oil so that when you go to lift the hood of your car, if there's not a lot of oil, that car hood can be a little bit heavy, but you oil that hood and that hood lifts a little easier. Well, they've got to open and close all those airways, and that pressure support just lets those airways open and close just a little bit easier so that their work of breathing isn't as hard. Pressure support, they're doing all the work themselves, but we leave a little bit of positive pressure at all times in their airway so that they don't have to quite open the airways as hard by themselves. They're doing all their own breathing, just leaving a little bit of positive pressure in there. We're not giving them a breath. They're breathing on their own. Just a little bit of positive pressure. PEEP is only in expiration. The ventilator gave them the breath on inspiration, and then when they exhaled, left a little bit of positive blowing pressure in there on expiration. So gas exchange can take place. Now, think about the balloon that has been left inflated. And instead of popping it, you untied it and let the air out. That balloon is going to look squishy, going to look yucky because it was blown up more than it should have been blown up. Okay. Well, the same thing happens or can happen to your alveoli, that we're supposed to blow up, take a breath, and go flat. Blow up and go flat. If we blow them up and not let them go flat, blow them up and not let them go flat, they're at risk for having some complications. Now understand, over here at the bottom of this slide, I've got to try to get my pointer up there. They're at risk for complications from being hypoxic too. So, you know, the old saying, you're damned if you do and you're damned if you don't, okay? So right now we're worried about hypoxia. We'll deal with the complications in a little bit, but let's keep the PEEP as low as we can. That maybe keeps them with the less hypoxia that we can. But what happens if we keep the PEEP on there because they're still hypoxic? We can have some problems. The first one is we can have barotrauma. Now, barotrauma is just a fancy word for tissue trauma. That's all barotrauma means, tissue trauma. So what can happen? Well, you can pop. You know what? You keep a balloon blown up too long and that balloon pops, doesn't it? You can pop that lung, and that's called a pneumothorax. And so you can get a collapsed lung. You do not have to know anything about a pneumothorax for this test. You don't have to know the care of it. You don't have to know anything about it except that it is a complication. You will know the care of a pneumothorax during test 3, which is trauma, when we do chest trauma. But you do need to know that a pneumothorax is a possible complication of PEEP. I gotta let somebody in just a second. Okay. But you don't have to know about care of a pneumothorax. Okay, so if that's right there in the book, right there, you don't have to study that, okay? The other one is sub-Q emphysema. Now, sub-Q emphysema is crepitus. It's the Rice Krispies under the skin. Air wants out. Air wants to go from higher concentration to a lower concentration. If air is kept in your lungs all the time, it will try to move through the tissues to get out here to the atmosphere. So sometimes people that are on PEEP for a long time get that Rice Krispies under their skin because it's trying to move out. And not common, but it is a possible complication, right? I'm gonna go to the third one now, bucking the ventilator. You and I are not used to having air in our lungs all the time. And if you always have air in there, you feel like you need to exhale. This is uncomfortable, not painful, but your respirations are not what you're used to. You feel like you need to blow it out. And so they get they can get agitated, and not like when you put them on PEEP, they can get very agitated, and you may have to sedate them if they start to fight their ventilations. The other one is it can affect your cardiovascular system. Because when you and I exhale, we decrease our intrathoracic pressure. We exhale air, that leaves room in our chest for blood to return to our heart. Our heart will expand, then it will contract and shoot blood out of our heart for our blood pressure. If I keep air in my chest all the time, because I'm trying to have gas exchange take place, then I increase my intrathoracic pressure. So when blood starts coming back into my heart and my heart goes to expand to fill, it's meeting resistance. Therefore, my filling is decreased. Therefore, my cardiac output is decreased. And I start to drop my blood pressure.
Janie, did you say that happens all the time, or it can happen?
It can happen.
So it doesn't.
If you start your patient on PEEP and they all of a sudden start to drop their blood pressure, they'll probably become tachycardic. They'll go in what looks like cardiogenic shock, tachycardia, hypotension. Then you know they are not tolerating that PEEP. Does it have to happen? No, we hope it doesn't. Our goal is no. But if it happens, you are expected as a nurse to recognize that. Absolutely. Absolutely.
So then would you decrease the peak?
Well,
level?
we would probably drop it to peak. Yeah, well, I mean, we would probably drop the peep down, and maybe we were doing the peeps so that we didn't have to increase their FiO2 so much. I mean, why were they on the peep is the question. What? Because sometimes, and I think there's a slide in here about oxygen toxicity. Sometimes they're on 100% O2. But sometimes if they're showing oxygen toxicity, maybe we thought, well, let's decrease their O2 to 80% and increase, and let's put them on 5 a peep. That way, I don't have to give them as much oxygen, but I can have gas exchange on both inspiration and expiration. So they're not hypoxic. Well, it didn't work. My blood pressure fell and my heart rate went up. Well, then they're going to have to just increase their O2. I mean, you got to figure out what's going on in the body. There's no black and white answer that all nursing students want, this nice black and white answer. How did it affect your patient? Negatively? Go back to the drawing board. That didn't work. Let's try something different. That did not work. Got to try something. Yes.
Is PEEP ordered intermittently, or kind of when it's ordered, it's for a set amount of time?
It's not a set amount of time. They will order PEEP. They'll probably start at low, like at 5 a PEEP. If they're still hypoxic, and they're not showing any of these signs like decreased cardiac output, they'll increase, and they're still hypoxic, they'll increase it to 10. If they're still hypoxic and they're doing okay, they might go up to 15. You rarely see it above 15 centimeters of water pressure, rarely. And then if it works and their PO2s are coming up, then they'll probably drop them down to 10. And then if they're staying, they'll drop them down to 5. And if they stay okay, they'll stop the PEEP. We want to use the less that meets the needs of the patient. But they won't say put them on for PEEP for a day and then take them off of PEEP. No, they're going to have to wean them type down. But they'll try real small amounts of PEEP first and see if it works. The more pressure, the more complications you're at risk for. I don't know if I answered your question or not. Okay.
So is it more like a as needed thing, like based
No,
off of?
it'll be ordered. It'll be ordered.
Okay, well, yeah, of course it'll be ordered, but for the doctors and stuff, or even when you're monitoring them, is it based off of like their lab values, and it's kind of like you're weaning them like to see what they'll do?
Yeah, it'll be off their ABGs. The fact that they can't get them they can't get them from being hypoxic. They're still hypoxic.
Okay, so basically you just have to monitor and see what they do, and that's when they decide when to take them off.
Correct.
Okay.
Now, understand that bigger tertiary care centers like CMC, for example, I can't speak for Pineville and I can't speak for University or in the smaller hospitals, but at a lot of your tertiary care centers, respiratory sets the ventilator settings. The doctors write them as like, I'm kind of making this part up, ICU care 1. It could be ICU care 3. I don't know which way's worse. And when the docs write them as that, then the respiratory therapist sets all the ventilator settings. They make all the orders for ventilator settings. And at CMC, it's almost that way. At smaller hospitals, respiratory doesn't usually do that. The docs usually write the settings. So it's all depending what's the policy of your institution. But at
Ms.
CMC,
Cheney.
respiratory can change the settings. Yes.
With PEEP, is it still the standard to do the ABGs within 30 minutes if the
Yes.
settings change?
With all ventilator changes, ABG should be drawn within 30 minutes. Yes, ma'am. Yes, ma'am. That's a standard of care. Absolutely. How do you know if it's good or bad? Okay. So you got a patient on ventilator. So what are some of the nursing responsibilities? Well, there's physical, which we're going to have on the next, which is the highest priority, but don't forget that there are psychological considerations also. When you can't breathe, you are very, very anxious. So don't forget that the patient is very anxious. They cannot talk. You cannot talk if you're on a ventilator. I don't care what you see on television. That is television. If the tube goes through your vocal cords, you cannot talk. So make sure that you give them some way to communicate, whether it's a point board or something to write with. Even though my poor daddy, I said, Daddy, could you write a little plainer? I can't read your handwriting. Some way to assist with communication. It is so anxiety ridden. It really is. The fact of not being able to breathe and not being able to communicate can be very, very, very anxiety ridden. You should be aware of your settings and check them frequently. Every 2 hours at least, you should say, I know they're on 600, 16, and 60%. And look over at that vent. And is that still what they are? Now, if they're not, don't change the vent. But you should be calling respiratory and saying, their FiO2 has been increased to 80%. What's going on? And they'll say, well, their latest blood gas showed this, and so we decided to turn their vent up. Okay, well, when they change the vent, I really want to know. Find out what happened. Don't you change them back. Find out why the vent settings were changed. Ambu bag always at the bedside, and the mask always taped somewhere or at the bedside also. You keep your alarms on. If your alarms are alarming, then call respiratory and find out why they are alarming. If the patient if your patient is unstable because they're alarming, then take them off and bag them until respiratory gets there. If they keep alarming but it doesn't seem like there's anything wrong, then leave them on there. But like their PO2s are good, their SaO2s are good, everything seems to be fine, then leave them on there. But if it's a high pressure alarm, then go over and suction them. If it's low pressure, find out why. Are they really being ventilated, or is there something wrong with the machine? But if you have any question, take them off and bag them until respiratory can get there. Make sure that humidity is being delivered. There should be water or some type of humidity being delivered. I think I talked about this on break. You're bypassing your oral and nasopharynx. That is where humidification takes place. We have to provide that humidification, or their secretions are going to get white, thick, sticky, hard to suction, and they are going to get in trouble. They must have some type of humidity being delivered. You keep drain the water out of the tubing. Just simply pick it up and drop it down into that bag about every 2 hours. If they don't have a bag, you simply disconnect it at the machine and drain it out into the trash can. That's all you need to do. And it'll work, no problem. Who's calling me? Okay. Try not to get any kinks in it. The patient can lay on the side of whatever's needed. Just make sure you don't have any kinks. Don't pull on the ET tube. Don't have any pressure. They've got these nice little holders that bring it off the ET tube and stick it. Just don't have a lot of pressure. Don't have the patient sitting there like this because you're pulling on their nose or that kind of thing. Just don't allow them to pull on the ET tubes. I'm not the biggest fan of restraints, but if the patient is at any risk of pulling their tube out, they should have some type of restraints on, whether it's the mittens. I really like the mittens better than just to hold their hands down, but don't let them pull their tubes out. They should be plugged into emergency outlets only, the red outlets, because if you lose power, as soon as the generator kicks in, the ventilator is going to kick right back on, and they kick on quick, like within 10, 15 seconds or something. So make sure that ventilators are always plugged into the red outlets only. Breath sounds are checked Q2 hours, and with each position change, we suction frequently, but only when needed. It should be no scheduled suctioning. When I was an ICU nurse, we suctioned Q1 regardless. That was a standard of care. There is no standard of care for suctioning now. You suction when your patient's breath sounds say they need to be suctioned. But you do not say, oh, I suction Q2 regardless. That is wrong. You suction when your patient needs to be suctioned. It is a sterile technique. Suctioning is aseptic. It is not clean. You use sterile technique when you suction. I talked about an NG or an OG to decompress the stomach. NG is sort of used as a synonymous term with OG. One goes through the nose, one goes through the mouth, but both are stomach decompressions. The first muscle to lose strength due to malnutrition is the diaphragm. Your patient must have nutritional support within a few days after being intubated, or you're going to have difficulty getting them extubated. IV fluids of D5 is not nutrition. It is not. A bag of D5, it's a little bit more than this. It used to be, I don't know why all of a sudden it got changed, but it used to be 108 calories were in a bag of D5. I think it's like 130 some now. I don't know where they got extra calories unless they just recalculated it. I don't know, but the typical maintenance IV fluid for an adult is D5 and a half at 125 an hour. So they get 3 liters a day. So if it was 108, which is what I always learned, even though it's changed, that's 324 calories a day. Wow, that's a Snickers bar. People can't live on 1 Snickers bar a day. You know, IV fluids are not nutritional support. They either have to have, if their gut is working, they need enteral tube feedings. If their gut's not working, they're going to need hyperalimentation or TPN. You got to give them nutritional support or you will never get them off the ventilator. Your job is to assess them. What does their color look like? What's their cap refill? Well, cap refill is in for respirations. But what's their work of breathing? What's their pulse ox? What's their ABGs? Don't let them extubate themselves. You know, if they need restraints, use them. If they don't need them, don't use them. They need to be turned every 2 hours to keep those fluids mobilized. And they need to be proned. And, you know, they're finding that with COVID. One of the most important things with COVID is proning these patients. And proning means putting them on their bellies. And this is just showing there's pads. Some people are using mechanical beds. But you got to get those secretions off of their backside. It is a posterior pneumonia, but it's not just COVID. Patients on vent should be proned. I will tell you, at one point, StickU did a great job proning their patients. I haven't seen them proning them lately, but at one time, it was a standard of care in StickU with all these patients with all these bad fractures. They would turn them at least once a shift, and they would put them on their bellies at least once a shift for 2 hours. But there's ways, you can see this person's intubated, and they would turn them and prone them. You want to move those secretions and proning. And I've read a lot of articles about COVID and how important proning is. My son was diagnosed with COVID and he's doing well. I mean, he's young and healthy. And I said, listen, when you go to bed at night, sleep on your stomach. Get on your stomach. His is really all in his head, but I mean, he's just got a head cold. He never would have been tested if it hadn't been for, thought he should. But I was just like, sleep on your belly, keep moving. Because probably you'll turn over, but I said, go to sleep on your belly. You need to be proned. Okay, and then we want to prevent ventilator-acquired pneumonia, and it's abbreviated as VAP, ventilator-acquired pneumonia, VAP. And we use the abbreviation hot SPUD. And I have to tell you, a student just called me that just took NCLEX and said, Janie, I had a multiple question about hot SPUD on NCLEX. I said, did you get it? She goes, I did. I got it. I can't believe it was on there. She goes, it didn't ask hot SPUD, but it asked, select all the following that would help in the prevention of ventilator-acquired pneumonia. And she goes, and I knew it from hot SPUD. I said, good for you. So you might want to pay attention because evidently there's a question in the NCLEX test bank about hot SPUD. So we use hot SPUD as the mnemonic. And so what will help? Well, unless it's contraindicated, you should keep their head of bed up 30 degrees, unless it's contraindicated. Oral care, we use the chlorhexidrine. It's a specially made packet that is it has a toothbrush hook to suction. It has the toothpaste in there. And then between the hours, it has like a pledget, like what am I trying to say? The little foam rubber thing, not foam rubber, the little foam pads. So there's a very specific oral care that is done every 2 hours. Poor oral care has been one of the highest things that's been shown to contribute to ventilator-associated pneumonia or acquired pneumonia. Oral care, 2 hours with the chlorhexidrine. Turn them Q2 hours to keep the secretions mobilized. Consider a sedation vacation. Consider, could we lighten them up? Could we maybe get them off the paralytics? Could we lighten up their sedation? That will get them moving more. That will get them over breathing the ventilator so they don't have a consistent ventilator, taking deeper breaths here, taking not deeper breaths at times. They should be on some type of peptic ulcer prevention. It will help with reflux, and which can contribute to aspiration, and DVT prevention, which is your prophylaxis for heparin or enoxaparin, which is Lovenox. So some type of DVT prevention. So all of those can help with ventilator-acquired pneumonia prevention. And then we got to get them off of it. We got to get them off the ventilator. Well, to get them off of it, number one, what put them on it? We got to get whatever put them on it off of it. So if they haven't gotten that impaired breathing, that they're not ready to be weaned off the ventilator. They have to be free of PEEP. If PEEP is what's keeping them from being hypoxic, then they're not ready to come off the ventilator. So they have to be free of PEEP. Their FiO2 has to be 40% or less. If they need a higher FiO2 than that, they're not ready to be weaned. They have to have spontaneous respirations, and they should not be extremely tachypnic. We'll allow them to be a little bit tachypnic, but not high tachypnic. They say less than 25. Satisfactory pulmonary function studies. That means they're pulling enough negative pressure for good spontaneous respirations and a good PO2. A good PO2. Their PO2 has to be greater than 70. Now, normal is 80 to 100, but they got to be between 70 and 80 at least. They should have an adequate level of consciousness. They don't have to be conscious necessarily, because we know there's lots of head injuries that are never going to be conscious and have a great Glasgow Coma score, but they can't just be completely obtunded usually. And they have to have good nutritional status. If they have things like these, they're not going to be ready. If they're massively infected, if they're anemic, they're not going to have enough red blood cells to carry oxygen, so maybe they just need a good transfusion. If they are extremely fatigued and sleep deprived, they are not ready to be weaned. They need to have good rest. If they are in extreme pain, now weaning is not painful. We don't have to pre-medicate somebody to wean them. But if they are in extreme pain to start out, they probably are going to be tachypnic. They're probably going to work hard to breathe, and they will not wean well if they're in extreme pain from the causative agent. And severe abdominal distension. They're going to be pushing up on their diaphragm, and they're not going to wean well. So when you go to wean them, you've got to watch that person carefully. You're going to explain what's going to happen, how you're going to wean them. Explain it to them, explain it to their family, tell them you're going to watch them, tell them you want them well rested, so don't let the family stay there all night and watch TV or play video games in the room all night. Typically, you're going to tell them you want them to sit up or in a position of comfort for them, and tell them that you're going to be watching them very closely. And I'll tell you, telling patients you're going to watch them is really important, and not just weaning. When I work night shift, I say to my patient, I'm going to come in here every hour. You don't need to wake up. I'll be watching you. When I'm in the ER and I say, this monitor, it's going to alarm all the time. Don't worry about it. I'm watching you. If that alarm is bad, you'll see me come flying through this curtain. Don't you worry. So don't worry when it alarms all the time for lots of different things. Most of it is you just moving. I said, so don't worry. My job is to watch the monitor. My job is to watch you. Don't you worry. I've got my eyes on you. I'm here to take care of you. And patients just kind of go, oh, okay. Because if you don't tell them that, those damn monitors go off every 2 minutes. Do you think I'm dying? Does she know it? Does she? It says right here, leads off. Does she know my leads are off? I know. I can see they're dead. She's in there talking. I know she's alive. Tell your patients you're watching them. Tell them you're the nurse and you're watching them. Don't worry. I know exactly. I'm taking good care of you. Don't you worry. That's my job to worry. You're fine. If for some reason they become unstable, stop the weaning. Their heart rate goes up. Heart rate goes down. Respiratory rate goes up. Respiratory rate goes down. Blood pressure goes up. Blood pressure goes down. Stop it. Stop it. They start to have sinus tach. They start to have PVCs. Stop it. They start working too hard to breathe. Stop it. They start becoming hypoxic. Their pulse ox drops. Stop it. They become unstable. Stop it. We'll do it again tomorrow or next day. Stop it. So what kind of weaning is there? Well, there's cold turkey. Pull the tube out, you on your own, baby. Go for it. This happens in the OR all the time. You have your surgery, they take your tube out, you go to the recovery room, you're on your own. Happens all the time. They have the SIMV method. You start picking up your breathing as they decrease your breathing. The machine quits giving you as many breaths as you start picking up your breaths. This is a little bit shorter term, usually maybe over a few days in the ICU, and then you typically get extubated. They might put you on a day of pressure support. And then the on-off method. We're going to take you off for a couple hours, and then we're going to put you on for maybe the next 8 hours. And then tomorrow we might take you off for 4 hours. And then we're going to put you on for maybe 8 hours. And then we're going to take you off for about 8 hours. And then we're going to put you on all night. And eventually, typically these people are off all daytime, and then we put them back on to go to bed at night. Then we put them off all daytime, and then we put them back on at night. This is more for people that have been intubated or on with a trach or whatever for a longer period of time. So we give them times when they're breathing on their own, and then especially at night, we put them back on the ventilator, and slowly but surely we will increase the time they're off the ventilator and then decrease the time they're on the ventilator until it's time to try it off for 24 hours. But this may take a month or two before we can get them off the ventilators. Okay. Any questions about mechanical, let me put somebody in, about mechanical ventilation? No? Okay, it's not that difficult. All right, I got a few minutes. All right, so we're going to go on to acute respiratory failure. Now, you've had acute respiratory failure before, and I even have already talked about it. Acute respiratory failure is basically hypoxia. It is hypoxia. It's a PO2 less than 60 when you're receiving oxygen with or without an increase in your PCO2. Now, this is the definition according to Lewis. You could pick up Iggy's book, Donna Ignatovich's book, and she might say less than 55. I don't care if you're saying 60. I don't care if you're saying 55. I don't care what number you're saying. Acute respiratory failure means hypoxia with or without an increase in your PCO2. That's the answer. Now, acute respiratory failure is a condition. No, I don't know what word I want to say. It's an overview. Okay, so the way I usually explain this, because students have a little difficulty with this, it means hypoxia. And I say it's an umbrella. It's an over umbrella of hypoxia. That's all it means is you're hypoxic. It's an umbrella. Now, hanging from this umbrella are spokes. You know what an umbrella looks like, okay? And hanging are medical or conditions that can cause you to be hypoxic, like pneumonia. Pneumonia is a medical condition. It's hanging from a spoke, and it's hanging from this over umbrella of hypoxia. Hypoxia is here, pneumonia, drowning, ARDS, acute respiratory distress syndrome, COPD, congestive heart failure. All these folks have sort of, I'll say, I don't know if drowning's a medical diagnosis, asphyxiation, choking. All of these conditions result in you being hypoxic. Now, the reason I say this is because some of you will go to other faculty and you'll say, can you explain this to me maybe a little better? And then the faculty will call me and say, Janie, which is worse, ARF, acute respiratory failure, or acute respiratory distress syndrome? And I'll say, It's not apples and apples. There is no which is worse, because acute respiratory failure is the category. It's like saying red, and under red is fire trucks and apples and Janie's shirt and I don't know, the Coca-Cola bottle. And, you know, red was the category. And then you have all these things that fall under red. Acute respiratory failure is this. And then you have all these things that are hypoxic. Okay. So what makes you hypoxic? So here's your normal ABGs. Your PO2 is 80 to 100. Your PCO2 is 35 to 45. When you have acute respiratory failure, your PO2 is down, you're hypoxic, and your PCO2 might be up. It might be down. It might be normal. Usually it's up, but not always. Not always, as you're going to learn in a few minutes. Okay? Now, listen to me. Put your little pencils. You don't have to put them down, but put your little eyes up here at your little computer screen and look at Janie, because I'm about to save you a bunch of time if you just look at me. The next thing, because we're going to take a break, and when we come back, we are going to talk about the 4 major causes of acute respiratory failure and a VQ mismatching. This is pathophysiology. I am not going to test you on pathophysiology. I am not going to say, you know, pneumonia is an example of increased alveolar or diffusion limitation. I am not going to ask you this. These next bunch of slides are not, I'm not going to ask you on a test. But why do I do it? I want you to understand what's going on inside of your patient's body that is going to make them be hypoxic. But I'm not going to have you memorize what is alveolar hypoventilation, what is increased intrapulmonary shunting. I'm not going to ask you this on a test. This is pathophysiology, and I'm not testing you pathophysiology. But we're going to go through it real quick, okay, when we come back. So I have 12:48. I'm going to see y'all back here at 12:58. All right. And we're going to come back and talk about these 4 conditions. And what would you see in your patient that when they come back from the OR, you go, or come back or come in from the ER, you're going to go, I better watch this person for hypoxia because they're at high risk. I'll see you all in 10 minutes. Emily Pagan, are you there?
Yes, I'm here.
Did you get a Zoom request from me?
Let me double check. I don't think so, but
You know, I sent one out, but I didn't get it either. So I'm wondering, I'll redo that
okay.
for tomorrow.
Yeah, that's perfect.
And it's not on my list either, so I don't know where it went. So
I say I don't
if
see
I don't get it to you tonight, I will send it in the morning, okay?
Okay, that's perfect.
Because I have to leave for Kentucky. Listen to me. I have to leave for Charlotte and take my grandchildren back and drive back here as soon as I'm done with class. So
Okay.
but
If
in
you
the
need to
morning,
change it too, I don't
I will get it to you
mind.
before 11, okay?
Okay, that's
But
perfect.
I am, I swear I sent it, but I don't know where who knows what, I don't know who I sent it to. I didn't send it to you or me, so somebody has it. But
No,
okay, I just was wondering. I'll get it to you though.
All right, perfect. Thank you.
It still go, but I did it. I just don't know where it is. It'll be somewhere. I don't know. Who knows? My Zoom's been acting funny lately though. I don't know what happened to it.
I was gonna say, I think I still have your number saved, so I can also text you, or if texting would be easier, I don't mind texting you back and forth as well.
No, I need a piece of paper. I need to talk more.
I gotcha. Okay.
Texting for me, texting. I can't even type with a typewriter. Well, there's no such thing as type on a keyboard. Oh no. Are you kidding? Texting.
Okay, fine.
No.
All right, no worries.
It's so funny. My son and daughter will both say, "Mom, just text it to us." I'm sitting there, you will talk on the telephone to me. I don't text. I mean, I like text. I like students to text me and tell me things, but no. If you think I'm going to text long things, forget it. And of course, then they say, "Well, just hit the mic button and talk to me." Well, my phone doesn't perceive my Southern accent very well. I read it. It doesn't say anything what I said.
Yeah, that normally happens to me too. It doesn't actually like read what I'm saying. So I get it. It's all good.
And I really got this one. It's not now, but it's when I got this phone, it was like the top of the line phone.
Mhm.
And it's been a problem child ever since I had it. I don't know. But I don't want to have to get a new one. I think as soon as I retire, anybody have Spectrum phone? Are they using Spectrum? Have you heard anything about Spectrum? I have Verizon. I've had Verizon for 20 years. But I think I'm going to switch to Spectrum. It's a lot cheaper.
I love Spectrum, but I also had what was that? The satellite internet, HughesNet beforehand, and it was the most awful thing. It was like Amish. I know they don't use electricity, but that's what it was. I would compare it to, and it was terrible. But I've been very happy with Spectrum services.
Oh, really? Well, I've had Verizon for probably 20 years. And this Lynn Jordan, who used to teach peds, was my best friend. She retired. I don't know. She's probably been gone 4 or 5 years. Maybe. I don't know how long she's been gone. She's been gone a long time. But she and I were gambling buddies. And we would sneak off. And we would go to Harris and Cherokee. And I think she had AT&T, but I'm not sure. I shouldn't blame her. And I could call whoever I wanted from Harris. I mean, and of course I could say, "Oh, we're at a conference in Raleigh." We'd be up gambling at Harris. And she couldn't get a hold of anybody. And so finally she said, "By golly, I'm going to switch to Verizon also because I got to be able to get through." So I knew Verizon had good coverage, but I think I'm going to switch. It's just so expensive.
I've had Verizon forever, and we just recently switched to T-Mobile.
Uh-huh.
They've been amazing. Like I've gotten service places I never even got with Verizon because now they're merged with Sprint T-Mobile, so they get service like everywhere.
Oh, really?
And they're pretty cheap and helpful. So
I have 3 lines, and I have unlimited texting. And I do pay. I think I'm paying for the phones on there too. So who knows? But I pay $294 a month for 3 phones. I think that's high. I think it's high. It may not be, but I think it's high.
I switched to Straight Talk from Verizon because they use Verizon towers, and my bill went from $150 a month to $55 a month.
Straight talk, what does that mean?
It's just a different phone provider, but they use Verizon towers. So you can keep all of your same stuff from Verizon. I took my phone and my Apple Watch over there.
Y'all have to excuse me just 1 second. I'll be right back. I know we gotta start.
Madison, is that for elderly or is that for anybody? And I just realized we're not talking about like home internet. Thanks, Caroline. We're talking about cell phones. So HughesNet was not my provider for my cell phone.
Fran, the reason I had said that is because my first job, like years ago out of college, was selling HughesNet, and it was probably the worst job I've ever had. So
because everybody like me would call and bitch all the time.
Caroline, that was at Red Ventures, right?
Yes, yeah.
Oh God, I'm so sorry.
Okay, I'm back. All right, let's get started. Okay, so we're going to talk about these 4 major causes of VQ mismatching. Now, I don't know if you've ever heard of VQ mismatching, but V stands for ventilation. Q stands for perfusion. So you have to have a working ventilatory system to have good oxygenation, and you have to have a good circulatory system, good perfusion. If you don't have them, then you're going to have a mismatching. Now, why is Q perfusion? Because P is phosphorus. P was already taken. Even potassium didn't get P. Potassium's Q. Oh, excuse me. It's K. Q, listen to me. It's K. And so perfusion is a Q. So VQ stands for ventilatory and perfusion mismatching. So there's 4 conditions that's going to result in a VQ mismatching. And if you have a mismatch, your patient is going to become hypoxic. So the first one is hypoventilation. With hypoventilation, it's on the ventilatory side. Okay, your alveoli, which is the little top one, is not being blown up all the way. It's open, but for some reason, you're not taking a good deep breath and you're not popping the balloon all the way open. Hypoventilating. So when you're not popping it all the way open, if I can get my pointer up there. Pointer. Oh, I know why, because it's still a pin instead of a pointer. That's why. So when it's not popping all the way open, then you're not going to bring as much oxygen in, and probably your CO2 is going to go up because you're not bringing as much CO2 out. But your blood vessel is perfectly fine. So hypoventilation has to do with the alveolar side. Okay. So it could be because maybe you have a CNS depressant drug. It could be because maybe neurologically you're having problems with that. So it could be that it's not even on the respiratory. It's just that maybe you have a disease that's not letting you take a deep breath. It could be because your neck is flexed and because you're unresponsive, or bronchial constriction. For whatever reason, you're not taking a good deep breath and you are hypoventilating. People that are hypoventilating, that do not take good breaths, are at risk for hypoxia. I mean, think of it. I got a patient not taking a good deep breath. They are at risk for hypoxia. Bottom line, that was pretty easy. The second one is decrease. Oh, no, this just talks about other conditions. I'm sorry. Decreased compliance. These are some more conditions. People with poor surfactant, people with too tight of dressings don't take good deep breaths. Abdominal distension, the belly's pushing up. They can't get their diaphragm down. All of these can result in people that don't take good deep breaths. So you take care of patients like this all the time. Okay, the next one is intrapulmonary shunting. Now with intrapulmonary shunting, typically it looks like this. And about 10 to 15%, we always have alveoli that don't pop open. But in this case, we have more alveoli that are completely closed down. So more than 10% are not having gas exchange to take place at all. So blood is just going past, with intrapulmonary shunting, blood is just going past alveoli that no gas exchange. They're not just not blowing up real good. There's no gas exchange taking place in a large number of alveoli. Okay. So that's what intrapulmonary shunting is. So people who have alveoli that maybe have problems going through it. So some of these could be atelectasis, which you know is collapsed alveoli. Well, that would be an example. Now, it can be more than one category that you're in. Somebody that has big mucus plugs stuck in there that are blocking off the alveoli, for example. Pneumonia that's having pus in those. Pulmonary edema, they're full of water. So gas exchange doesn't take place because they're full of water. PE is a little different, but it can affect it. But you deal with PE more than something else. But all of these, just think, alveoli where there's too many that gas exchange aren't taking place at all. So that's even worse than hypoventilation. So that might happen.
Janie,
yes.
How does the like the mucus plug thing work, and how can it have such an effect if it's just like in one little alveoli? You know what I mean? Like,
well,
or do you have multiple?
The bigger the mucus plug, the larger the tree that gets blocked. The bigger the tree that gets blocked, the more alveoli that are affected. So you can have a huge mucus plug. This happens in babies all the time. You see this in NICU all the time, where all of a sudden they've got to get a mucus plug out of these babies or they'll arrest. So if it's a huge mucus plug, they can die from that. Adults can die from it. If it's a little mucus plug, not so bad. They won't. You only lose a little bit of shunting. Big mucus plug,
how do you get it out?
Huh?
What's the process of getting it out? Just suction or coughing?
Suction, and probably, we don't do it routinely, but you can use saline and irrigate it, hook it to an ambu bag and start blowing it around and hopefully break it away from the walls and maybe be able to move it up. That's
perfect. Thanks.
What we do. Okay, pen. Okay, so increased alveolar dead space. Okay, with this, the ventilation is fine. However, something's wrong with the blood vessel. So the alveoli is perfectly open, but the blood vessel is narrowed. So there's something in there. And so what we typically see this is like with a PE or microemboli, or somebody who's with a PE, your alveoli is fine. It's the blood vessel that is affected. So again, PEs are very common, emboli, or let's think about the patient who we just put on PEEP and we decrease their cardiac output and they go into cardiovascular collapse. Their blood vessels are starting to if there's not enough blood in them, they clamp down. And so gas exchange doesn't go past those vessels in the lungs that are clamped down. There's no clot in them. They just sort of, no blood in them either, because we didn't pump out enough blood out of the heart. So they're stuck down in the feet or down in the vena cava somewhere. So in the increased alveolar dead space, people whose blood pressure has dropped is going to be hypoxia. People with clotting disorders are going to, and the clots going to the lungs, are going to be at risk for hypoxia. Low blood pressure is hypoxic. Clotting disorders, hypoxic. Because of increased alveolar dead space. And then diffuse limitations. Any condition that causes a diffusion of the O2 and the CO2 to be impaired. Okay, so what do I mean by that? Oh, that's not a pen. I have to go back. I'm sorry. I meant to hit the pen button and I didn't. Oh, come on. Pen, Janie, pen. There we go. Nice open alveoli. Nice open blood vessel. But This is 1 cell thick. Yep. Yeah, I have to remember which screen I'm on. I'm sorry. It's not as easy as y'all think it is. Okay. This is 1 cell thick. This is 1 cell thick. If for some reason the cell wall becomes more than 1 cell thick, or it's blocked by something else, then it's going to have problem with oxygen diffusing into the bloodstream or CO2 getting out. So what could it be? Well, it could be it could be pus, pneumonia. What if pus got down in here? Well, now oxygen has to move through pus. What about coronary artery disease? Well, or not coronary, arteriosclerosis. That's what I meant to say. Arteriosclerosis, coronary artery disease being the heart, arteriosclerosis. What about diabetes? Where you get the plaque on all your blood vessels. What about congestive heart failure? The blood vessels themselves are okay, but fluid starts to come out here. So now instead of nothing, I've got to go swimming through some water. And now this starts to move up into my alveoli. So now I've got to go swimming, not just between, but I've got to go swimming through fluid in my alveoli itself. So congestive heart failure. ARDS, which you're about to learn. Same thing. So anything that increases fibrosis, cystic fibrosis, this is one of the things that kills these people. It becomes scar tissue on that. The oxygen can't get through the scar tissue. It can't go into the bloodstream. They become hypoxic. So this is diffuse limitation. So any patient that, that could be a problem. That's diffuse limitation. So you got to think about this. Is it something that affects my alveoli and is affecting my oxygen getting in? Is it something that's affecting my blood vessels? Then my patient is at risk for hypoxia. And if I have this, my patient is at risk for acute respiratory failure. What do we do for acute respiratory failure? Well, they're therefore at risk for impaired gas exchange. What is it? A low PO2 with or without an increase in CO2. I think that's all I talked about. I believe O2 and CO2 is gas. Sounds like gas exchange to me. It is impaired gas exchange. That is what acute respiratory failure is. I got to watch them. Look for signs of hypoxia. Do y'all remember the signs of hypoxia? Somebody tell me what they are. Do y'all remember? You remember the mnemonic?
I don't remember the mnemonic, but it's cyanosis.
Okay, well, I heard it.
RAT.
RAT. What does it stand for?
Restlessness, anxiety, and tachypnea.
Restlessness, anxiety, tachycardia, and tachypnea. First signs of hypoxia. Restlessness, anxiety, tachycardia, and tachypnea. Your brain needs 2 things to live: oxygen and glucose. You got to have oxygen. You got to have glucose. If they don't have enough, your patient, they get restless. They're anxious. They start picking at their sheets. You ever seen an old person pick at their sheets, at the top of their sheets? They start picking at the tape around their IV. What is this? It's not all Alzheimer's. It's restlessness. When you hear that word restless, you think hypoxia. Restlessness, hypoxia, restlessness, hypoxia. Always. It is hypoxia, hypoxia, hypoxia. Restlessness, anxiety, tachycardia, because they're trying to move more oxygen around. What did I tell you? The first dysrhythmia associated with hypoxia is sinus tachycardia. They're trying to move more oxygen around. Tachypnea, they're trying to suck in more wind. They've got to get more oxygen in there, sucking in more wind. Okay? So, late signs, well, I hope you picked it up before it got late. We send them to bed. Bradycardia, extreme restlessness, and dyspnea, but those are late. Those are late signs. I want it during restlessness, anxiety, tachycardia, and tachypnea. follow their pulse ox, follow their ABGs, position them for areas for the best breathing. What is that? Almost always it is sit them up. Sit them up. Sit them up. When I was this has nothing to do with this test, but when I was at Kentucky, we did general surgery and we did bariatric surgeries. And these people would come in up, believe me, when you came in to have your gastric bypass done, unlike in today's society, you're in the hospital for a month. You came in like a week in advance and then you stayed for another month afterwards. And so when we had these patients come in, they weighed 500-600 pounds, 700 pounds on them. We had these huge lazy boys. They were we called them bark loungers. And they were very well padded. They had pads bigger than I can do on the screen. And they were hooked on a track to the wall because these patients slept. You think, when I say they slept in a lazy boy, you think, well, okay, I can understand that. Their head was up, but that's not how they slept. When they slept in positions of comfort, they would put their knees in the lazy boy, put their arms toward the back, and then lean down this way, especially the women, because their breasts were too heavy and they can't lay down because they couldn't breathe because of their breasts. The breasts probably weighed 100 pounds each. So when they couldn't lay on their stomachs because they can't get down there. But when you got in the lazy boy and leaned forward, you got your breasts off your chest. Head of bed was up, breasts were off your chest. They slept great. But our lazy boys, we were afraid they were going to flip them over. So we had them on a track and they would just slide down so that they wouldn't flip over. And these patients, what's the position of comfort? Usually sitting up, but not for these patients. These were with their knees in a lazy boy and their chest up. And they almost all slept that way. Almost every single one of them slept that way. So set them up to a position of comfort. O2, they're hypoxic. Give them O2, sure. Keep their airway patent, whether it's positioning, whether it's suction, humidification, whatever's needed to keep an airway patent. Meds as needed, whether it's a bronchodilator. Somebody tell me a bronchodilator.
Albuterol.
Albuterol is a bronchodilator. Anybody know another one?
Terbutaline?
Terbutaline is a bronchodilator. It is. You're right, it is. Have you ever heard of aminophylline? Or theophylline?
Theophylline, yeah.
Theophylline, you heard of theophylline? Aminophylline and theophylline? They're another one. Probably albuterol is the most common that you know, probably. Might give them a bronchodilator. They might be on steroids. They might be on your montelukast, which are your mast cell inhibitors to prevent future asthma attacks. I don't know. Who knows? Whatever their condition is, whatever they need. Encourage rest periods. They don't have a lot of activity intolerance. We typically will give them, you want to give them their breathing treatments before they eat. Give them a breathing treatment and then rinse their mouth out. Afterwards, breathing treatments taste nasty. So you give them a breathing treatment and then you feed them so that they have a little bit more energy to eat. It takes a lot of energy to eat. So someone that is short of breath doesn't eat very well because it takes too much energy to eat. Breathing treatment first, rinse their mouth out, then feed them. These are not patients that you say, here, let's go walking down the hall. Here, I want you to give yourself your bath. People that are extremely hypoxic, you have to help. And it's not, I'll wipe anybody's tail. I don't care when they can't do it themselves. I don't mind a bit. And this would be a patient that you need to help because they can't do it themselves. And then keep an ongoing assessment. Keep watching them because they can crash quick. They can crash real quick. They're hypoxic. They're hypoxic. They can crash really quick on you. Okay, so acute respiratory failure is the category. Now, you've heard about PEs before. In actuality, you learned about DVTs, is what you learned about in 151. You learned about DVTs. But you know that 98% of all PEs come from DVTs of the lower extremities. So a PE is when a blockage of something comes up and blocks the pulmonary artery, and it came from a thrombus. Now I want you to remember that a thrombus doesn't come from anywhere. It built where it was. NCLEX deals with that a lot. It's not on your test from me, really, but people forget that a thrombus didn't break loose from anywhere. A thrombus built where it was. And embolus came from somewhere else. I mean, pathophys as well as med-term. So a thrombus didn't break loose from anywhere. It built from somewhere, and then it breaks loose to make an embolus. So where did it do? This one came up typically from the lower extremity. It came up your saphenous vein, okay? Came up, went through your vena cava to your superior vena cava, went in through your right atrium, went into your right ventricle, shot out your right ventricle to your pulmonary artery, got to 1 cell thick pulmonary artery and stuck, okay? It can't go out your left ventricle. If it broke loose from a heart, people say a heart attack or whatever, it can't go out your left ventricle, go out your aorta, go down your femoral artery, go through a 1 cell thick capillary bed down in your foot, come up your femoral, saphenous vein and stick and cause a DVT? Well, no, it would have stuck in your 1 cell thick in your foot. A thrombus doesn't come from somewhere else. It would get stuck in your capillary bed. It had to develop. It doesn't come from anywhere. A thrombus develops. An embolus comes from somewhere else. Okay, so this embolus came from probably your lower extremity, went through your right atrium, right ventricle, came up into your pulmonary artery, and it got stuck. So blood coming out of your right ventricle, trying to go through your pulmonary artery, and then through your 4 pulmonary veins back into the left side of your heart, which is trying to go out to your body. Blood can't flow. How much blood doesn't flow? Depends on how big the clot is. That's the important thing. If it is a big clot, then not very much blood gets to your left side. If not a lot of blood gets to your left side, then not a lot of blood gets pumped out of your left side, and you will have a cardiac arrest. You will go into VFib and you will die. And here's an example of a really big clot, and you will die. First patient I ever had die on me was a PE. I was walking him for discharge, and he dropped dead in the lobby of the hospital and died. First patient I ever had die. After having his gallbladder taken out. You stay in the hospital for a week after gallbladder surgery in the olden days. If it's just a little bunch of small clots, it probably won't kill you. But if you throw a big clot, enough that you block the blood flow going back to the left side of the heart, it will kill you. The guy that owns Belk's died that way after having his gallbladder out. It all has to do with the size of the clot, because it blocked the blood flow. Okay. More than 90% of PEs come from deep vein thrombosis. So, and we use the term venous thromboembolism, VTE, to describe the spectrum from DVTs all the way to PE. So any of the clotting disorder is referred to as VTE in today's literature. Okay. Now, so it affects both the pulmonary system and it affects the hemodynamic changes, hemodynamic meaning cardiovascular changes that occur by blocking of the pulmonary artery. And it has to do with the fact that gas exchange isn't taking place because blood isn't going past the alveoli, so gas exchange is affected. And blood didn't get back to the left side of the heart, so perfusion is affected. So that's why you're going to get hypoxia, no gas exchange, no blood flow, and you die from the hemodynamic changes of no blood flow going into the heart, no blood flow going out of the heart. Okay? Okay. So what do? You got to remember that we got to watch all the signs for Virchow's triad. Now, you learned Virchow's triad probably in 101. You probably heard about it again in 151. You heard about it in A&P. And that is, this is the mechanism that is for clots. I'm not going to spend a lot of time on it. But the more situations you have for this, the more at risk for clots that you are. Stasis, blood flow. Slow, sluggish blood tends to clot. If you're not ambulatory, if you're not moving, if you're not doing range of motion, if you're getting dehydrated and your blood is stagnant, if your blood is thick, you are more at risk for clots. So it's your bed rest, it's your post-surgical, it's your patient that's not moving, it's your dehydrated patients. All of those patients are at high risk for the development of clots. Injury to the intima of the blood vessel, injury to the lining of the blood vessel. So people that have had surgery and the blood vessel is cut, people that have had a lot of sticks are at risk. People that have coronary artery disease are at risk because that's injury to the intima, to the lining of the blood vessel. The more injury, the more sticks, the more surgery you have, the higher at risk you are for developing of clots. And the last one is hypercoagulability. The more your blood will clot, the higher at risk you are. So who has hypercoagulability? Again, dehydrated people have hypercoagulability. The OB post-delivery, postpartum patient has hypercoagulability. The minute your placenta detaches, you go into a form, your blood clots faster so that you don't bleed to death. For surgery, when your body releases norendocrines, it says, you know what? They just cut into you. I'm going to keep you from bleeding to death. I'm going to make your blood clot faster. That's a compensatory mechanism. That's good. You don't bleed to death. You're at risk for clots. That's bad. But your body doesn't know that. So the fact that you had surgery makes you in a hypercoagulable state. That's why not everybody, but most people are put on heparin or enoxaparin, which is Lovenox, after surgery because of the release of the norendocrines. Not just because you're not walking around or moving, it's part of it, but your body went into a hypercoagulable state. So you are at risk for developing of a DVT or clots, and it makes you more of a risk for a PE post any of these. So what are some signs? PE, sudden onset. It was in your leg, I'm fine. It breaks loose. It takes maybe 1 to 2 pumps of your heart. Sudden onset of dyspnea, shortness of breath, air hunger, tachypnea, tachycardia, tachypnea and tachycardia, sudden air hunger, sudden dyspnea, sudden shortness of breath. It is not insidious. It is sudden. 85% will have difficulty breathing. 84% will be tachypnic. 83% will have pleuritic chest pain. And Abigail, describe pleuritic chest pain to me.
It'll feel like you can feel it like in the vessels. Like when you breathe, it's hard to breathe,
Okay.
right?
Increases when you take a deep breath. How about was that Boudreaux or Whistler?
Boudreaux.
Okay, Abigail Whistler. What else besides her increases with deep breath? What else is a sign of pleuritic chest pain? How do I know the difference between pleuritic chest pain and cardiac chest pain? How do I know if you're having a PE or if you're having a heart attack?
I mean, it's going to be worse when you're coughing and breathing.
Okay, it increases with deep breaths It could increase the cough, I guess. Diamond, do you know?
It's more like sharp and stabbing.
Correct. It is sharp and stabbing and increases with it when you take a deep breath. So when people come in the ER and they go, oh God, oh God, oh God, oh God, I'm having a heart. Oh God, oh. They are not having a heart attack. That is pleuritic. Sharp and stabbing and increases with deep breath. That is pleuritic. Okay. Very sharp. Elephant on the chest, substernal, it can radiate. People that come in, sit down and go, I'm having chest pain. On a score of 0 to 10, 0 being none, 10 being the worst pain of your life, what would you call this? It's a 10. That's butt pucker. My butt pucker goes, whoop, whoop. Oh yeah, this is real. Cardiac is very stoic. They don't move. You do nothing, and Jane will talk about this, you do nothing to increase your myocardial oxygen demand. They don't jump around with, oh God, oh Lord, oh. They don't do any of this. That increases their chest pain. That increases their myocardial oxygen demand. They don't move a muscle. Oh, my chest is really hurting bad. Oh yeah, it hurts really bad. Yeah, it's bad. Is it worse? It's getting really bad. That's cardiac. That is cardiac. They do not bounce around. Okay. So they have pleuritic, not substernal crushing. They get a sharp and stabbing pleuritic pain. They will have rales. They will have crackles in their lungs. Getting about 50. They might cough. They will become tachycardic. They might have a low-grade temperature. But typically, sudden onset of shortness of breath and tachypnea and air hunger. And it comes on very, very quickly. Well, how do we treat it? Well, first of all, don't get it. We know post-operative patients. We know patients that don't move a lot, patients that are post-surgical, patients that are postpartum, patients that are obese. We know that these are the highest risk patients. Get up and walk them. Get them out of the bed and get them walking. If you're in my clinical group, I would say to you, have you walked your patient? And you would say to me, no, physical therapy hadn't been here yet. And I'll say, have you walked your patient? No, I didn't ask you if physical therapy's been here. I said, have you walked your patient? Get your patient up and walk them, unless it's contraindicated. Get your patient's butt out of the bed and walk them down the hall. They hate you. You're going to get them up and you're going to walk them. That is the number one thing you're going to do. You've got to get them out of the bed and you've got to get them walking. That will prevent the PE the most. And don't tell me you're going to wait for physical therapy. Now, if it's your first time up after a hip replacement, yeah, you're going to wait for physical therapy. But as a whole, you got to get these patients up and get them walking in the hall. STDs are good, but they don't replace walking. They don't replace walking. TEDHOs are good, but they don't replace walking. Active and passive range of motion are good, but they don't replace walking. Watch their vitals. Medicate them. If they're in pain, give them pain medicine so that they will get up and move. They will turn. They will walk. They will cough. Don't be stingy on the pain medicine, especially in the first 24 hours post-op. The more you make them comfortable, the more they will move and the more they will take deep breaths. First 24 hours post-op is the most critical time for pain control. The nerve endings are exposed. They are throbbing. They will atrophy down in 24 hours. That's why PCA pumps are only on there for 24 hours. It is the most important time for pain control is in the first 24 hours post-op. Give them their pain medicine, including C-sections. Why you all in OB will not let these poor women have pain medicine? I'll never know. You have to lie.
Speaking of C-sections, I work on mother baby as a tech, and I'll say within the past month they changed the protocol. So like if you have a C-section, you have to get up and walk within 6 hours. Good. And you have to walk 3 times a day, and that's like fairly new. So the fact that you brought that up, it just made me think about that.
Do they give them anything for pain?
Yeah, they do. If
What?
they want it.
Tell me what they give them.
Just Lortab.
Well, that's good. That's at least something.
Yeah.
My daughter had hers up in Greensboro, but she had pain after her C-section, and they brought her 200 of Motrin. I said, okay, you get 20 minutes. And next time they ask you, your pain's a 10. She goes, well, I don't think it's a 10. I said, it is, because you're going to have to lie to get some for pain. And so that, when she pushed her button, she looked at me and I said, it's a 10. Tell me it's a 10. She goes, it's a 10. And they brought her a Lortab. And that's all she needed. But dear God, give her something for pain. Okay. Assess them for your DVT. Do your Homans. Looking for, okay, so Jonathan, describe a DVT to me. Tell me one symptom.
DVT, you're definitely gonna have pain in that area.
Okay, Addison,
Wherever
give me
DVT
another
is.
symptom. Addison Neff, are you there? Addison, did you sneak out on me? Or maybe you did. Amy Duke, are you there?
Hey, I'm here.
Give me a sign of a DVT, please.
Like warmth and swelling in the area.
Very good. Bianca, give me a sign of a DVT, please.
The area is gonna be hot.
Hot, red. Caitlin, sign of a DVT.
Shortness of breath?
No, that's PE. That's a PE.
dang
This is
it.
down in their leg.
Is it gonna feel hard to move the extremity? Is there gonna be pain?
Pain, okay. Yes, Bradley, does it have a pulse?
Most likely not.
It does.
Okay.
It does. I tricked you there. But I want you to remember that a DVT stands for deep vein thrombosis. Veins do not affect your pulse. Your artery affects your pulse. If you have questions, maybe not for us as much as NCLEX, but if you have questions that say you have a weak pulse, you have a thready pulse, that's affecting your artery. Veins do not affect your pulse. So the pulse, blood got in just fine. Blood can't get out. Veins have pulses. Let me rephrase that. I said that wrong. The pulse is not affected by a venous problem. Veins do not have pulses, but the pulse is not affected by a venous problem. So if your patient has a pulse, it's a venous problem. If your patient's pulse is not correct, it's an arterial problem. Okay, so yes, it has a pulse. Now, Bradley, what might prevent you from being able to maybe palpate that pulse? Do you know?
Maybe the inflammation around the area.
Inflammation resulting in what?
Decreased blood flow. I don't know.
No. Okay, how about you, Chris B? What else does that leg look like?
The inflammation would result in edema.
Edema. So with DVTs, lots and lots of, the problem is in the vein. Lots and lots of blood gets in, but it can't get out. So the blood is in there. It's hot. It's red. It's swollen. It's painful. But the pulse isn't affected because it's not on the arterial side. So the pulse is fine, but it's so swollen, you might have trouble feeling the pulse. Now, if it's an arterial clot, which doesn't have anything to do with this, but if it's an arterial clot, then it's going to be cold and blue or white, and the pulse won't be good, and the leg will not be swollen. It'll be sort of flat or mottled or shiny or something. But if it's a venous, lots of blood gets in there. It just can't get out. All right, now, if they have a bleeding problem, they're at risk for bleeding, so they might have some other problem. We cannot put them on anticoagulants. Okay? So we still don't want that thing to come up their saphenous, up through their their vena cava to the superior vena cava, through the right atrium, right ventricle, into their pulmonary artery. But we know they got a big old DVT there. And we know if it gets their pulmonary artery, it can kill them. So people that have a problem with bleeding, like a hemophiliac, for example, or somebody with some kind of bleeding disorders, or someone who has a cerebral hemorrhage, or someone who has had a bad eye injury and we can't give them an anticoagulant because it'll make them lose their eye, or something like that, okay? Then we're going to do something to stop that clot, and we're going to put in what's called an IVC, a inferior vena cava filter. And so it's put in the inferior vena cava. These are some pictures of some of them. And it's going to catch, if that clot breaks loose from their leg or their arm, it's going to catch that clot as it goes through their vena cava and will prevent it from getting stuck in their pulmonary artery. We typically just use these on people that have some type of bleeding disorder that cannot take anticoagulants. Which one? Depends on which one your hospital buys. So how do we diagnose a PE? Well, we can do a D-dimer on them. A D-dimer is a test that says, it doesn't say they have a PE, but it says they have clotting going on somewhere in their body. It is a byproduct of clots. It says there's clotting going on. I can't tell you where it is, but there's a clotting disorder going on. And that's what a D-dimer is. If you have a hospital that has it, they can run a helical CT, a spiral CT. Not all hospitals have a spiral CT. It's cost a lot of money. I have to tell you, and they may have it now. This was several years ago, but they also run spiral CTs for kidney stones. So my good friend was at a hospital, and they were ruling out a kidney stone in her. And so she says, I got to go. She goes, I'm having my IVP done and I got to go back down to have the second scan done. I said, oh, you are not. She's a nurse. She taught nursing with us. I said, you are not having an IVP done. She goes, I am. I said, you are not having an IVP. I said, nobody does IVPs anymore. She goes, Janie, I am. I said, surely they did a helical CT on you. She said, Janie, they don't have a helical CT here. Now, this hospital, you may have heard of this hospital. It was called CMC Pineville. Now, they may have a helical CT now, because this was probably somewhere between 5 and 10 years ago. But don't think that you have to be in some Band-Aid station out in the boondocks. This was part of CMC's network, and they did not have a helical CT at that time down in Pineville. So I don't want you to think that everybody has a helical CT, because they don't. So it's kind of interesting. So we do another thing called, well, let me go on down. ABGs will tell you something. Pulmonary angiogram. We don't typically do pulmonary angiograms, but they could squirt dye and watch the dye through that, but those can be really dangerous, so they don't typically do those. So they will do what's called a ventilation perfusion scan. Now, a ventilation perfusion scan, also called a VQ scan. Everybody calls it a VQ scan. It is a nuclear medicine scan. And so what they'll do is you'll go down to nuclear medicine and you will breathe a radioisotope. So, they'll pinch your nose, they'll put a spirometer in your mouth, you'll breathe in this isotope, and then they will put the scanner down and they will scan your lungs. And they will make sure that this isotope went through all your lungs and that you didn't have like a tumor or something that didn't let your lungs show up. And then after that, if your lungs look good, they will then inject this radioisotope. It's not a dye. It's not an iodine-based dye. It's just a radioisotope. They'll inject it, and then they'll watch it go through your lungs. And remember, this is on the vessel side. So if the vessel is blocked, then you're going to have an area that's not going to show that it got to it. And that would indicate a high probability of a PE. So this is one. Now, right here, this is not the ventilatory. This is the perfusion side. So this one's here, not this side, because this is a lateral, so it's only going to show one lung. But these right here are the two lungs. So look, this lung picked up the isotope, but this lung did not. It picked it up here. It did not pick it up here. So the fact that not both lungs were picking it up made this is the vascular side, this is the perfusion side, made this a high probability of a PE, VQ scan. Ventilation, perfusion scan. Do what?
Sorry, I don't think we could see your mouse, like where you're circling, if you were.
You are correct.
Sorry.
You are correct. Just a second. These here are not it. These here are laterals where they only see one lung because they're only looking from the side. Okay, so it's not these. That's why I have it off to the side. It's these. So this should show two equal lungs. It should show blood flow that's equal. And as you can see, they are not equal. All right. So the fact that the radioisotope did not go equally through the vasculature of the two lungs, when this was interpreted by the radiologist, it was interpreted as a high probability of a PE, that there was a blood clot that is blocking the lung field over here on this lung. I don't know why. I mean, I don't know if they flip it or what. I don't know, but it was that lung that was the problem. And that's what a VQ scan was. Okay. Now, I want you to look at these ABGs down here, because I told you acute respiratory failure is hypoxia, a low PO2 with or without an increase in the PCO2. Usually, there is an increase. When you hypoventilate, you retain your CO2, and it's a blood test, and that's what they're measuring inside your body. Anytime you are tachypnic, you will blow off your CO2, and CO2 is your acid. PE is a sudden onset of air hunger, tachypnea, dyspnea. So with your PE, you become hypoxic, but you're blowing off your CO2, so you also become hypocapnic. Hypocapnic is a low CO2. Why? Because you are tachypnic. When you are tachypnic, you are hypocapnic. People that are tachypnic are going to blow off their CO2.
Say that again, Janie. People that are tachypnic
will blow off their CO2. I'm blowing it off. So when you test it in my blood, I'm going to have a low CO2. So I'm hypoxic because I'm not getting any air. I'm hypoxic because I can't, my vessel's not moving, but I'm hypocapnic because I'm blowing off the CO2 that's in there.
I have a question really quick.
Sure.
So with the VQ scan,
yes.
So they breathe in the isotope and then they scan the lungs and then they inject the isotope as well through the vein?
Yes.
Okay.
And then they scan them again.
Okay.
The first one, they looked what happened when they breathed it. The second time they scan them, they're looking at what happened when they injected it. So one is ventilation, that's the V, and one is perfusion, that's the blood vessel, that's the Q. Perfusion is Q.
Okay, thank you.
Mm-hmm.
Since it's an isotope, do we have to worry about any kind of allergies with the injection?
No, not really. So what do we do? What do we do for a PE? We typically put them on a heparin drip. Right. And remember that heparin does nothing to the clot that is there. It just keeps it from getting bigger. But it will not break down the clot that is there. It keeps it from getting bigger. Heparin does not break down clots. If it's a big enough clot and the patient is symptomatic, then they might give them a thrombolytic, such as TPA, streptokinase, urokinase, Retivase, something like that. And Jane will talk about that with clots in the coronary vessels when she talks about heart attacks. And your antiplatelet. Somebody tell me an antiplatelet, please.
Aspirin.
Aspirin. Anybody know another one?
Plavix.
Plavix, which is clopidogrel. Clopidogrel. I don't know if I'm pronouncing it right or not. That's the generic for Plavix. Tyclid, Persantine. But most of them know Plavix more, and aspirin. So what do we do for a PE? Well, it is an impaired gas exchange. They are an acute respiratory failure due to your VQ mismatching, your anticoagulants, your thrombolytics, your antiplatelets. Watch for RAT, restlessness, anxiety, tachycardia, and tachypnea. They're hypoxic, so they're going to need oxygen. Position. This is always a kicker on NCLEX. Anyone who is at risk for clots, so they're hypercoagulable, they have a history of PEs, you do not set them in a high Fowler's. You just put them in a Fowler's. So sometimes they'll ask, you got a patient with a history of PEs, or they think they have a PE, do you set them in a high Fowler's, a Fowler's, or a low Fowler's? You put them in a Fowler's. You do not set somebody with a clot that you know has a clotting disorder, like their D-dimer's up. You do not set them where their groin is in a 90-degree angle, because that increases your chance of getting a clot in your groin. So you want to set them so that they're more, look at my belly. You want to set them so that they have this sort of Fowler, so that there's more of a 45-ish type degree angle right here, than to set them straight up so that there's a 90-degree right in their groin. Okay. So high Fowler's for people with known clots is not a correct positioning. Pulmonary toilet. Somebody laughs at those words. Pulmonary toilet is just turn, cough, deep breathe, center spirometer, PMPD, anything that flushes out the lungs. Keep the lungs clear. Keep them flushed out is all pulmonary toilet is. Monitor their ABGs. If they become too hypoxic, then bag them or help intubate them or whatever's needed. If they have to be intubated, fine. Whatever it takes. Just a couple more slides and we'll be done with PEs, and that's where we'll stop. They also remember, the problem with PE is if you block the blood flow going to the left side of the heart, then they're going to block the amount of blood going out of the heart, so they can show signs of cardiogenic shock. So they're going to go tachycardic, they're going to drop their blood pressure. So you're going to watch for signs of the hemodynamic effect also. So look for signs of shock, tachycardia, and hypotensive. That's the most common thing you're going to see. Watch for any signs of bleeding, because they are on an anticoagulant. So they could have, ecchymosis, which is bruising. They could have hematuria. They could have hematemesis, which is the correct way to pronounce vomiting blood, hematemesis. They could have epistaxis, which is nosebleed. They could have subconjunctival hemorrhages, that's bleeding in your sclera. Melena, that's blood in your stool. All of these are med terms that have to be brought forward in case you were to see them in a test question. You should know where they are bleeding from. Watch for signs of bleeding. Remember that a PT is for a patient on Coumadin, warfarin. A PTT is for a patient that is on heparin. If I ask you, I haven't seen the test. Me, NCLEX, whoever. If I tell you a patient is on heparin and I give you an abnormal PT, it's not the right answer. Because I didn't tell you anything about warfarin. I'm asking you about a PTT, not a PT. You got to make sure your blood tests go together. A PTT is about a patient on heparin. A PT is about a patient on warfarin. They have to be the right drug with the right lab tests. It has to be, they have to go together. And I think I already talked about this. About feeding and altered nutrition. I think I said this. Allow for periods of rest, small frequent meals, feed after the respiratory treatments, and keep a good calorie count. If you've never done a calorie count, there will be a piece of paper or a printout from the dietary, and you look at their tray and you pull that printout and you say, oh, they ate half of their turkey, they ate all of their tomato soup, and they ate none of their peas, all of their cake, and all of their tea. And then at their door, there'll be a clipboard or a little manila envelope, and you take that menu and you stick it in there, and that's how you do a calorie count. Very simple. And
about the bed rest for the anticoagulation therapy, doesn't putting them on bed rest increase their risk of getting a blood clot?
Well, they already have it. While they're on heparin, we're gonna put them on bed rest because we don't want any more of that clot to break loose for right now. It used to be they were on bed rest for like 6 weeks. Now it's only about 2 or 3 days until they get their PT at 1.5 to 2.5 times normal.
Okay, thank you.
Once they get them anticoagulated enough, then they can get up. Just stay calm. Stay calm. I know it's time to go. Stay calm. Give them some pain relief. If their legs are hurting, they can, this is the last slide. They can have pain medicine. There's nothing wrong with that. They can, if their legs hurt, you can put a nice wet, warm cloth on their legs. It's fine. Bed rest will help their DVTs, but let them have their pain medicine. People that are in pain need pain medicine. I believe strongly in pain medicine. All right, y'all, thank you for the extra couple minutes. And we're going to start on Tuesday with ARDS. And if you don't remember your ABGs, go back to 152 because I go through them very quickly. Okay, I'll see you all on Tuesday.
Thank you.
Thank
you.
Thank you.
I can stay here for questions for a few minutes if anyone has any questions.
I have one question for you,
Sure.
Jane. Are we expected to know normal D-dimer? I don't
No.
think okay.
I don't even know a normal D-dimer. I just know it's positive. Positive D-dimer means that there is for clots. That's all I know. And that's what they usually will say. Their D-dimer is positive.
Okay, thank you.
Mm-hmm. I don't even know what it is.
Danny, I know you said that the IVC filters were used for patients that can't take anticoagulants.
Usually.
But could you use it, like someone who was on bed rest and couldn't move and you're scared that it's breaking apart, would you ever use it on a patient like that?
They can. Like they'll sometimes do them with trauma patients sometimes in the ICU that aren't moving around a whole lot. And they also are kind of worried about them that they don't really have a clot, but they're worried or bleed, but they're worried about them. Like, do they have a hematoma somewhere that they haven't picked up on? So rather than take a chance, they might go on and put an IVC filter in them. So they haven't seen a hematoma on their spleen or something like that. But if there's a chance, they may just go on for safety's sake and put one in instead. But I wouldn't say that it's routine by any means. They got to have a pretty good reason on why they would do it.
Thank you.
And this isn't really anything that's on a test anywhere, but you'll see a sign above their bed. But when I don't know if you know what a guide wire is, but when they put in like a central line, they'll sometimes run a guide wire in and then pull the cannula out and then run the soft cannula over the guide wire and then pull the guide wire out. If you can't use just a normal guide wire. You have to use a straight guide wire when you do this. And so there'll be a sign above the bed that says what kind of guide wire that they have an IVC filter in it. So it takes a very specific guide wire. So they can't use just a regular guide wire on those patients because they'll knock that filter out of there. So, when they're putting in like an IJ or a subclavian, they have to use a specific guide wire. That's not a test anywhere. It's just kind of interesting. So if you're saying, what? They'll say IVC filter, do not use such and such guide wire in case you're precept in like an ICU or something. It's kind of interesting.
So those filters that they put on IV lines, those are just for air bubbles then? Just curious.
Air bubbles mostly. They also catch crystals. So if you have a drug that has crystals in it, like I will talk about mannitol having crystals, and Jane will talk about Dilantin having crystals. They have to be given through filter, either a filter needle if you're giving them push, or if you're hanging it as a drip, you have to have a filter on those because it catches crystals. But usually, like on the end of a hyperalimentation or going through a central line, they're there for bubble catchers. Yes, that's not an IVC filter. That's just a different, or like a filter for blood, like this kind of filter for blood or something like that. That's for catching clots when you're given blood transfusion. So that's different than an IVC filter. So that's different. So,
Miss Janie.
Yes.
I know in one of our previous classes, they talked about hypoxia and like when to give oxygen and everything, considering like if their patient has like a comorbidity that requires them to like have their CO2 level makes them breathe instead of their oxygen level making them breathe.
COPD, yes.
Will that be something that we need to take into consideration?
Well, yes, you always have to take that into consideration. Absolutely. Typically, a nurse can start 2 liters of oxygen without a physician's order. Okay, because 2 liters is not going to stop anybody from breathing. So you and I, unless you have COPD, you and I breathe because our CO2 levels get high. We don't breathe because of our oxygen levels. We breathe because our CO2 levels rise. And we have chemoreceptors in our aortic arch and our carotid bodies that say, hey, your CO2 level's high. Take some breaths and blow it out of here. I mean, that's the way we typically breathe. COPD patients always have high CO2 levels. So if that was the case, they would never take a breath. So they breathe because their PO2 levels are down. So if you gave them some oxygen, a high oxygen load, they may not breathe. Now, please understand, it would take a pretty good bunch of oxygen to make them stop breathing. But that's why they say you can use 2 liters. But it would take a lot of oxygen to do that. 2 is not going to knock anybody's breath out. So you can start 2 liters, and then we would say, then what would you do? Well, you would call the physician and say, we had to start oxygen on Mr. Smith, okay? And if 2 liters didn't help him, then we would go up some more, okay? Now, in answer to your question, we would need to pay attention to that. But if Mr. Smith needs more than 2 liters or needs more than 2 liters, let's see, 1 liter takes you from 21 to 26%, and you go up by, I think it's 4% after that. So I think 2 liters takes you, it either takes you to 28 or 30. I'd have to look again because I don't teach fundamentals and I'm not exactly sure what each liter takes you. It's either 2 or 4. I'm not sure. But okay, so you know, we've got him at 28, maybe closer to 30, maybe probably 28%, I would guess, 26 to 28-ish, I would say, at 2 liters, from 21 to 26 to maybe 28. Okay. But he still looks bad and he's struggling. Well, you know, we got to keep going up with him. We have to keep going upward. The man's going to die. And as you will hear me say often, dying is not very therapeutic. And we're kind of here to be sort of therapeutic. So, so we got to do something. But would we consider things like that? Sure. Because sometimes if we shoot for a pulse ox or a PO2 of 98 for this patient with COPD, we'll probably never get him off the ventilator. He'll be ventilator dependent for the rest of his life. So for the COPD patient, I'm probably looking at, if 80 to 100 is normal, we're probably looking to get him at 70. And he'll probably do just fine at 70. So, you have to look at every single patient as an individual when you're caring for patients. It's not my decision. But I would, as a nurse, you sit there and say, gosh, this person has a PO2 of 70 and we're going to start weaning them off the vent. Oh, and normal is 80 to 100. Why are we doing that? Well, I should know that they have a history of COPD and we can't keep increasing his PO2 or we will never get him off the vent. That's my job to know what is the role of what does a PO2 do to the COPD patient.
Okay.
So I don't know if I answered your question or not.
That makes sense. I just ever since they told us that fact, I've been weary whenever I see administer oxygen. I'm like, well, what if they have this problem?
Well, the chances of you knocking out a COPD or to quit breathing is, well, let's put it this way. If you knock them out, you're going to have to bag them. If you don't give them oxygen, you're going to have to bag them. You're damned if you do and you're damned if you don't. So it probably didn't make a whole lot of difference if you want to know the truth.
Okay.
You're not going to, they're going to arrest either way. So have at it. Enjoy yourself. I don't know what you're going to do about it. Call for help. That's about all I can say. Yeah, it probably won't happen either way. That's just what they don't want some little beginning nurse to sit there and put 8 liters per nasal cannula on somebody because they're scared they're not breathing real well. Is what they're trying to. And 2 liters by practice, I don't think there's a law. That is the standard of care. You can start 2 liters without a physician's order. If I was up on the floor and I needed more than 2 liters, would I give more than 2 liters? Absolutely. Without a physician's order? Absolutely. But I would have my reasons of justification on why I did it.
I'm going to just call the physician right after to talk.
Sure. I probably would have somebody else on the phone with them. But I would be monitoring their PO2s, their SaO2s, their pulse ox, their color. How are they doing? What's their respiratory rate? What's going on with them? What were my justifications for what I did? And I can't imagine that anybody would ever dispute as long as I stayed within what was needed for the patient. Well, you can, more than saying, well, I put my 2 liters on and he just didn't get any better, so he died. Well, good for you. Come on. That's not good. You got to do something. You got to do something better than that than just say, well, they don't do. And I know it's hard when you're first starting. It's so hard because you don't have any experience to back yourself up on. You haven't had things happen before to make any decisions from. I tell the story often about, I was up on 11A with students. And we came out of pros conference. So it was probably, 8:30, 8 o'clock, 8:15, whatever time it was. And there was a student that had been ours and she just graduated. She probably just came out of orientation on the floor. And she grabs my arm and she goes, "Don't you leave me." I'm thinking, she's not one of mine. And she goes, I said, "What's the matter?" She goes, "My man is not doing well and don't you dare leave me." And I thought, well, who is it? And she gave me the room number. And of course, I've got my clipboard going, do we have this man? I said, I don't think we have this man. She goes, she's not yours, but don't you leave me. I said, okay, he's not ours. He says, not yours. I said, well, tell me about him. She said, they put an epidural in him this morning. And Janie, he's not doing well. And I immediately said, okay, I'm going down to that room. I said, and as I walked down the hall, I stuck my head into the utility room and I grabbed an Ambu bag and I said, "You get me some Narcan and a syringe and you meet me down in that room." And he was at the very end of the hall. And by the time I got to the room, he was in full arrest. He was almost basically at full arrest. And so I started bagging him and she walked in there and I grabbed the Narcan and I just pushed him pushed it in there. About that time, help was on its way. And she said, I would have never thought what to do. She goes, I had no idea. She said, you knew when I told you, you didn't even see him. You knew exactly what to do. And I said, honey, I've been a nurse for 40 years. What, he had an epidural put in this morning. They give narcotics. He's an old man with narcotics. He quit breathing. I got to breathe for him and we got to reverse his narcotics. And they got him back. She goes, I didn't know what to do. I said, because you haven't experienced it yet. This will happen. It will come back. Get somebody that knows that has experience. I guarantee you the next epidural patient you have, you're going to say, I'm going to damn well make sure there's an epidural. There's a ambu bag in that room. And I'm going to make sure I may stick some Narcan in my pocket. Because I saw it happen before. It's not going to happen to me again. And that's how you grow. That's how it happened to me once. I'm going to be on the lookout for it again. And that's how you grow. That's how you learn. And believe me, I've stood there with my finger up my butt going, huh? I didn't know that. That's how you learn. That's all I can say to you. That's how you learn. And hopefully there's somebody that knows what they're doing beside you. I don't know. But as a student, we won't let you kill anybody. I promise. We won't let you kill anybody as a student. And your preceptor won't let you kill anybody.
That's reassuring.
Almost. I've done it a long time. It's very rare that we have a situation that we even come close to a student killing a patient. It's happened almost, but not really. It's very, very, very rare. Very, 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 very rare. Very rare. So you'll be fine. Don't be scared. We'll be fine. I promise. You'll be fine. We'll teach you. We'll get you there. You'll be surprised by the end what you do know. So we'll get there. Any other questions? Don't just hang in there. You'll be okay. So do some studying. Go to SimLab. And she may ask you questions about burns, which you haven't had yet. Just listen and use what brains you think you have and say, well, I think I would do this, or I think I would do that, or glance through the burns PowerPoint, at least the PowerPoint. And what is on those PowerPoints? What did I concentrate on? I talk a lot about fluid resuscitation. Well, I guarantee you that she will have, I don't know what she talks about in the sim, if you want to know the truth. But I guarantee you it's going to be about fluid resuscitation on that burn. I guarantee you, because that's 99.9% of the care of the burn patient is fluid resuscitation. So I guarantee you, I would know something about fluid resuscitation when you go into SimLab. And, at least look through the PowerPoint and just glance through it about what do I talk about for the care of the burn patient. And because I guarantee you that's what she's going to concentrate on. I think. Maybe not, but I think so. I haven't been in there. I don't know. But that's what I would concentrate on if I was in there. Okay. Anything else, ladies or man? I don't know who's all in there. I can only see four faces and me. I have to drive to Charlotte and back, 3.5 hours up and 3.5 hours back this evening. Okay. Y'all take care. Call, text. Let me know what you need. Oh, stop my recording.